Hello, listeners. Kaylin and I are new at this, and I'm still trying to figure out how to record and edit sound. I promise that this episode is still really interesting, even though I wish it sounded a little better. Enjoy! Welcome to Placebo, the podcast where we talk about healthcare and other things. I'm Logan Richards, and this is my sister.
And I'm Kaylin Richards.
And today I have a question for you, and hopefully some interesting things that you will want to learn about.
Okay.
So the question that I was interested in for this week was, does the way your hospital look affect your recovery?
Like how your room looks?
Yeah, like how the building is, where the windows are, where the bed is.
Okay, well, I hadn't thought about that topic much.
No? I suspect that you have some thoughts, though.
Definitely.
Okay, so let me start with this. Can you guess the one design intervention, we'll call it, that affects the largest number of outcomes in the hospital?
Design intervention. Paint color.
It's not paint color.
They talk about paint color a lot on HGTV.
Oh, okay.
Not paint color? Well, let me try one more guess.
Okay.
How about lighting?
Lighting is not the most effective, but it was at least talked about in the
Oh,
research.
they didn't talk about paint color?
They didn't talk
well,
about...
terrible paint color can make you feel sad.
I bet that it's probably an issue.
What if your paint color looks like barf?
Not in the research that I read. Perhaps more research needs to be done into that.
They always say that.
Yeah, they always do.
Okay. Well,
okay.
What else did you find?
All right, so let's get into this. The research that about this is kind of, they've taken the evidence-based medicine kind of mantra and they've turned it into evidence-based design. And so there actually is a whole kind of section of research about the design of your physical building,
sort of
the
branch
hospital.
Off of universal design.
Yeah, perhaps. So there's one guy who seems to be kind of the guy when it comes to evidence-based design of hospitals. His name is Roger Ulrich.
Roger.
And at the time of this last review that he did, he was at Texas A&M. I don't know where he is now. I think I found he looked like he was in Sweden or something.
Spreading his knowledge around. Okay.
Yeah. So the one thing that they found was had the most changes to patient outcomes in the hospital was single bed rooms.
Oh, yes, for sure.
You would have known that?
Well, yes, because we've recently switched. We were all single bed rooms for a little bit. Now they're getting some double beds back. But it makes a big difference when your neighbor's not shouting or watching TV or talking loudly to their doctors about all their problems.
So let me just get to the page here. And I can tell you the few things that... So single bed rooms, they went through and they have this really handy table on this review that shows all the things that have strong evidence. So single bed rooms have strong evidence that they reduce hospital-acquired infections.
Well, that makes sense.
Improve patient sleep. Improve patient privacy and confidentiality.
Right.
Improve the communication with patients and family members, and increase patient satisfaction in their healthcare experience.
Yes, patients. One of people's biggest complaints is that they can't sleep.
Yeah. So I thought that was interesting because we've been to a lot of hospitals, and
you have been.
I have been.
Talking about me and you.
Both of us
in our lives.
In our lives, and I don't. Do you find that single bed rooms are very common?
Well, like I said, we had become more and more towards that at my hospital. But I don't know that they're that common. And I will say when I was in England, and I went to the hospital there just because I was curious, I noticed that most of their rooms were larger wards. They had like 6 to 12 beds in the room.
Oh, wow.
Yeah. And I thought, because I'd seen that on old-timey British shows, and I thought maybe that was a historical thing and not current, but it seems to be current, at least in the hospital that I went in there.
Interesting. I would say that at least this research definitely suggests that that's probably not the way to go.
6 to 8 beds or
No.
whatever. Yeah, no, I was like, wow, that's a lot of people. And they just had curtains, between each of the beds.
Yeah. Well, that's interesting. So the one thing that they point out about single bedrooms is the hospital acquired infections.
For sure.
They say right now, actually this was in 2002, the data that they took, so it's probably changed, but in 2002, 1 in 22 patients in the hospital got a hospital acquired infection, which basically amounted to 1.7 million people. And that cost the healthcare system approximately $5 billion a year, which is a lot.
Yes.
And so it seems like changing from a 6-bedroom to a single bedroom might be worth the cost.
Right.
Can you guess some of the other things that were important that showed some strong evidence to affect patient outcomes?
Design, you said.
Design things. Yeah, okay. These are all design things.
I think a lot of things. Design. Gosh. Accessible bathrooms. Maybe
okay.
That's not maybe on their list, but some of the newer rooms in our hospital are so much more pleasant because you can walk into the bathroom with a walker and not have to walk sideways. Or
I think that's definitely part of it.
Design. I would say larger rooms is on the same.
Yeah, trend. Larger rooms were in there actually.
Yeah, because I think maybe in older buildings the rooms were built smaller because they didn't use as much equipment. And now we have a lot of equipment in the rooms and they just get so full up and there's no room to move around.
One thing that I was reading, which maybe you haven't thought about, is that larger rooms were actually shown to prevent falls.
Oh, that makes sense because they're not tripping over things, probably.
That was what I was thinking too at first, but actually they reported that it was because family members were more likely to spend more time in the room.
And so people were supervised?
Yeah, so basically people had more supervision. If they had a larger room with places for family members to sit, and they found that family members spent more time with their family that was in the hospital, and that reduced falls. Since we're on the topic of preventing falls, what do you think about bed rails?
Bed rails are controversial because you can't have all 4 up. That's a restraint.
Right.
Or classified as a restraint. You could have up the 2 upper ones. That's what we usually have unless someone is on restraints. What do I think about them in general?
No, do they prevent falls?
Oh. No, probably not.
Yeah, I think you're right. The evidence is kind of controversial, but I found a statistic that was cited in this review that said 27.8% of falls near the bed were due to the bed rail. Like they
thought they were grabbing for it and they missed it?
Yeah, I think it kind of like a false sense of security almost.
Yeah.
So that was certainly interesting. It was kind of counterintuitive, I thought.
I think I use them if people need something to hold on to when standing up or when pulling themselves out of bed. But I don't really think of them as a fall preventive measure.
Yeah. Okay, let's talk about something that we haven't mentioned yet, and that is the amount of light that comes into the room.
I said lighting.
Well, you said lighting, but I'm not talking about
lighting.
I'm not talking about lights from a light bulb. I'm talking
window
about
lighting.
Yeah, so what do you think about windows and views of nature?
Oh, I would love a view of nature if I'm not feeling well.
Yeah, that's true. The views of nature have been shown to reduce pain and reduce stress.
Of course, a lot of hospitals are in cities where there might not be a lot of nature to view.
Yeah. So I saw an example of one that it had a good view over like a city park. I don't remember where it was. But they had a before and after picture. In the first one, there was this tiny little window, and you could barely see out and like maybe see the sky, and it was kind of like high up in the room. And they just took the whole wall and made it a window, and then you could see this beautiful park. And
our rooms have very large windows.
The other thing that I noticed...
Of course, a lot of people want to keep the blinds down all the time.
Yeah, which is interesting. So do you have a responsibility then to say like, well, actually the light and the view of nature has been shown to make you feel better?
I do. If the person seems like they might be a little confused, especially, I will encourage them or put the blinds up because that can help with delirium or preventing delirium. If they just say the light's hurting their eyes, I won't put the blinds up if they're not confused or something. But I think that is one thing that's important.
What do you think about, so the hospital that you work at is in a city. There's probably not a lot of nature views, maybe building views.
You can see the water from some of the windows.
So what do you think about artificial nature though? Maybe like doing like a screensaver on all the TVs of nature or pictures of nature.
They have the Nature Channel.
Yeah? Do they do that?
They have a channel that just shows kind of like scenes of nature, and it will be like a little brook running down for a while. They'll just show it for a while, and then it'll be like some deer in a meadow, and then it plays kind of like gentle classical music in the background.
That's nice. Do they do that all the time, or does someone have to turn it on?
It's one of the TV channels, so you have to pick that channel. So they'll put it on, especially a lot for people that are really sick or confused, or maybe with dementia. I think as a calming.
That's interesting.
Calming thing. Yeah.
Yeah, that's cool. So yeah, views of nature had strong evidence to support that they reduced pain and reduced patient stress, and then had some supporting evidence to say that it might reduce depression, length of stay, improve patient satisfaction.
I'm just going to put the Nature Channel on for everybody.
Yeah.
No more stressful news shows.
Let's see. What are some of the other ones I wanted to talk about here? We've talked a lot about improving patient outcomes. And I think that we've mentioned a lot of the strong evidence that helps improve patient outcomes. What do you think about improving the way that staff can care for patients? I know that you mentioned bathrooms already.
Yes. I think making equipment accessible or supplies accessible.
Yeah.
So when that can be stocked close to hand or in the rooms, that makes it a lot easier. Especially things like linens or things that you need a lot, like socks, emesis basins, toothbrush. Those are the things I use.
Yeah.
Yeah. When things are easily accessible, you're not having to leave and go in and out of the room a whole bunch.
Yeah.
Like flushes for the nurses.
Going in and out of the room a whole bunch is a good way to reduce risk of the hospital-acquired infections too.
Not going in and out of the room.
Right. Yeah. If you spend your whole time working with the patient in the room, and not going in and out and possibly touching, surfaces outside the room or something.
Right.
Well, that's good. So the only evidence that the report that I read cites that decreases the risk of staff kind of negative outcomes was ceiling lifts.
Oh, well, yes, we have some of those too, or mechanical lifts in general, I think.
So you and I are both, you're an OT and I'm a PT student, so we have some training in transfers of patients. Do you think that ceiling lifts are important because other hospital people don't have as much training in transfers, or are they important for your work too?
It depends. I mean, I generally, if the patient that I'm working with can participate in a transfer, if they're at that stage, I definitely want to, if there's a way that we can do it safely, want to do it with them so they can work on weight bearing and strengthening. But if they cannot safely do that, and we just want them to be able to get into a chair to work on their sitting tolerance or things in sitting in the chair, then the lift is still useful for therapy.
Yeah.
But I think for like nursing staff, it is really important for those patients that are not easy to transfer, because otherwise they're not going to get out of bed at all. And it's so important for them to be out of bed, to get stronger, to be for their lungs to be able to clear and to not get pneumonia, to not get DVTs.
Do you think that the reason that back injuries and that sort of thing among people that work in the hospital is common is because, or what do you think the reason is that back injuries seem to be a common thing that is worth reducing the risk of?
Well, I think it's because people want to have good people know about body mechanics, but it's not practical a lot of the time, because you can't get into a good position because of the equipment, because of the setup, because of the patient's, body type, whatever. You can't be in a safe position for good biomechanics. And a lot of the time, if a lift is not convenient, people are just going to push through it.
Yeah.
You know.
And that causes injuries.
And that causes injuries. And it can be dangerous, right?
Yeah.
For you or for your patient, for both.
Yeah.
And then that can also cause, if it's a stressful experience for the patient, then they don't want to do it again. They get scared to get up out of bed. And that kind of causes more problems in the long run for them too.
All right, just reading here now that what you mentioned before about, I just saw that decentralized supplies, like what you were mentioning before, increases staff effectiveness. So that's what you were talking about.
Yeah.
That's the only category that it has a little bit of evidence to support. So another thing that I want to talk about is the hospitals that I've been in have these centralized nursing stations, kind of these places where the medical staff will congregate, where the computers are.
Mm-hmm.
But there's actually a lot of evidence in here to support that decentralized nursing stations, meaning smaller areas, more spread out around the floor or the area of care, is better in a lot of ways. What do you think about that?
Well, what does it say that are the ways that it's better? Does it specify?
Well, one way that I found it was interesting was reducing patient falls.
Because they're closer to the patients to notice if something's going on.
Yeah, and I think that they have less detachment from, from the people that they're caring for at that time. Closer to be able to react quicker.
I would say
the other thing that it suggests is kind of vague, but increasing staff effectiveness.
It's kind of vague.
Yeah, well,
I could study result is that?
Well, this is a table of the overall. I could go back and look at the specific study that gave that evidence.
Yeah, I mean, I think that's true. I know that in like the newer areas of the hospital where I'm at, the newer floors that they've built, they have less. They still have kind of a central nurse station area, I would say, with like a greeter or with someone who's watching monitors, stuff like that. But in general, the nurses are more broken up and sit usually where their rooms are. Even on the older floors where they don't have that newer layout, the nurses have their own computers on wheels that they would take and kind of usually stay in the area where their rooms are and kind of park in that area.
Yeah. So
they're not all going down to sit at the nurse's station when they're not, directly with their patients. They're usually staying right around the rooms. And I think that you're right. They're more aware of what's going on with their patients if they're there in the area.
Yeah. So you kind of brought something up. So you work at a hospital that has an area that has been newly built or newly remodeled.
Right.
As well as several areas that are much older than that.
Right.
What do you think are some of the changes that you notice as you go from different areas of the hospital, the changes that are important to you that help with your ability to care for the people you're working with?
Well, I think a lot of things are things that we've talked about already, like the decentralized supplies where there's supplies in the rooms. So if you realize, I need some washcloths, they're in the room already stocked. You don't have to go get them. Same thing, like there's walkers in all the rooms, and I'm often using walkers with people, so it's nice that they're already there. You don't have to think about bringing it or getting it.
Yeah.
The rooms are much larger with more space to move around and with space specifically for families, like a couch. And the bathrooms are huge. There's ceiling lifts. I think we kind of covered a lot of all
we covered
things,
all of it.
Right?
So, but in general, it kind of gives, it seems like it gives you the chance to be a more effective healthcare practitioner, kind of.
It's a lot less planning in advance, I would say.
Do you think
because
you're able?
Things are just set up to be more effective. Yeah.
Yeah. Do you think the people that you see staying in the newer rooms have better outcomes than the people you see staying in the older rooms? Like maybe they leave the hospital quicker, or.
In some cases, yes, because some of those floors are more short stay floors.
Yeah.
So it's a little hard to say.
You have to
the same,
control for the type of people you're seeing.
Right. I don't know. It would be really hard. You would have to control it a little bit better. I will say it is a little difficult because sometimes someone will be on one of those newer rooms and then their status will change for whatever reason and they'll be transferred to one of the older rooms.
Oof, I would be so frustrated. I would go back to my old status.
And it's a little bit of it's a little bit of a letdown, or a little bit, it's just more difficult sometimes for them to get
Yeah.
around. And so I think patients notice that it's more difficult for them. So maybe it's an effect. I don't know.
Okay. So what do you think about this? There's going to be times when you can't have a very good design
Right.
room. So what do you do to make up for that? When you know that there's a better spot and you could sometimes the design affects the way that you come into the room and the effectiveness of your treatment. How do you make up for an older, less well-designed room?
Well, I mean, I guess you just have to be a lot more prepared in knowing what you're doing and hopefully bringing stuff when you come, so you're not having to leave and come back a bunch of times.
Mm-hmm.
And then knowing, like, it's just maybe a matter of experience in that environment and knowing the best way to get around in it, because like I know how to tell people to get into the smaller bathrooms, or
Yeah.
I know that you have to put the head of the bed up so it shrinks so there's enough room to walk around the end of the bed, or to move the pumps at the end of the bed. So I think it's more, if I wasn't experienced in that setting, it would be a lot more frustrating.
Yeah.
If you just worked in larger spaces and then one day went into this small space, it would be a lot harder.
Yeah. What do you think your responsibility is as I mean, it seems clear that the evidence suggests you can get better outcomes with certain design features of your hospital. Obviously, you're not going to be designing those or really have any way to change them because of how permanent a building is.
Right. I mean, I think the overall goal is to move towards the newer spaces, but you can't just.
So what is your responsibility to change the environment or the room that someone is in to try and get better outcomes? And I don't mean taking down a room and building it bigger, but
no, I know what you
you
mean.
mentioned like nature already. You might open the windows for them.
We can't open the windows.
Well, I mean the blinds.
The blinds. Yeah. Oh yeah, we do things like turn someone's bed so that it's facing the window when they look out, so they can see the view out the window.
Yeah.
Or move furniture, rearrange the furniture so that their chair is by the window if they want to sit in it, or take things out of the room if it's too crowded, if we can,
Yeah.
We do things like that. Get equipment that is accessible for the patient, so, if they need a bariatric commode or a raised toilet seat or something like that, to make it more accessible for them. Does that make sense?
Yeah.
I don't know.
Cool. Well, that was all the kind of categories. There's some other things that I kind of didn't mention along the way that were interesting. Do you know how many air changes per hour in a room is required by law?
How do they even measure that?
I don't know. Okay. I assume that they have machines.
All the air is different.
Yeah.
I don't know if that's measurable.
It says 12 to 15.
Well, that's pretty good. Otherwise, it would smell pretty bad, probably.
And then the other interesting thing is that they said that you need to think about who the patient population on the floor. Mm-hmm. That will help you determine what the air direction should be. So you can either have air coming into a room and then leaving through the doors and the windows, the cracks in the environment, or you can have that's positive pressure, or you can have a negative pressure room, which is where air is being sucked out by the ventilation systems and coming in through the outside, like the cracks under the door or another.
So I think most of our rooms are negative pressure.
Yeah.
But we have some positive pressure rooms.
So positive pressure, I was reading, was important in like immunocompromised, like maybe in the cancer care environment, because if you have air coming in from other spaces that could have an infection in the air coming into a room, then that's not what you want. So you want the air flowing out of the room.
And they also use it for people on airborne precautions.
Yeah, well, that's basically the same thing, right?
Well, so people that have diseases that can be communicated through the air. So not droplet, but like through the air.
Oh, well, then that's a negative pressure room.
Is that negative? So
yeah, because you want that patient's, the room in their air, you want that air to go into the ventilation system and be filtered.
It goes out, yeah. So that's for people with TB.
Yeah.
Right.
So that's the opposite of someone who's immune compromised. Okay. They would want their air coming in fresh and filtered and leaving.
So most of them are that, and then there's a few rooms on several floors that are for people with like TB or what's the other one? They get when you get shingles, but it gets into your lungs.
I don't know.
I forget what it's
called. What about hand washing stations?
Disseminated, I think is what it's called. Oh, so that's another thing. So we have some where they're in the hallway.
Yeah.
And I think that's probably better.
Mm-hmm.
Versus where you have to wash your hands in the patient room and the door maybe is a little bit away from the sink, and maybe the paper towels, the patient has been, taking paper towels out of that same thing. That I feel like that probably is a little bit contaminated. It's better to have hand washing stations in the hallway, I think.
Yeah, I don't know if I read that, but the one thing that I did read is that increasing the number of hand washing stations decreases the amount of risk for hospital-acquired infections, but also that hand washing stations should not have, at least ones that are meant to be used by the healthcare providers, should not have handles to turn on the water. They should only have foot pedals.
We have foot pedals, and then we have the newer sinks are motion.
Yeah, or that, I suppose.
Yeah, and the soap too.
The other thing I didn't mention, and it was because it was, I couldn't actually get a hold of it, is there's a whole document that is requirements by law what the design of a hospital should have.
Okay.
And so the only thing I could get a hold of was the Washington State amendments to that document. So what I gleaned.
We're in Washington State.
Yeah, right. What I gleaned was, which doesn't give you a lot because they mostly say this document's good, but we want to change like this word. And so all I could see was like where they changed the word and not the actual, because the actual document costs a lot of money. But this was an organization that went and they set the rules for how hospitals should be designed.
Okay.
And they're updating things pretty constantly, it seems like. But one inconsistency that I found is that when I did the literature review of trying to find this evidence-based design and the looking at the different features of the hospital, there's almost no evidence. In fact, I didn't find any studies after 2010, which is it's 6 years later now.
Yes.
There has been 0 studies on this since 2010 that I can find, which seems, I don't know, it seems weird to me.
It seems weird.
Because it seems...
But maybe there's no money in it.
There could be no money in it, and that is a real possibility. But who knows?
I don't know.
Anyway, so all the data that we have is fairly old. Like
2010 or earlier. I'm kind of wondering about, did you get any data from other countries? Because like I said, I noticed the hospitals in England had so many beds in the room.
I should look for more in other countries. This Roger Ulrich guy is kind of like the foundation for all the research that I found, because he's been around for quite some time, and this big literature review that he did was more than just his studies, but kind of they were all influenced by original ones that he did. And so no is your question, but I'm also
maybe
sure
maybe Roger's retired. Maybe that's the problem.
No, I'm pretty sure I googled him. I'm pretty sure he's in Sweden right now.
Or he's just enjoying some Swedish nature.
No, I think he's at a school in Sweden. Yeah, it says, okay, so I'm assuming this is the same guy, because here he is.
A different Roger.
No, he's at the Center for Health Design, so it's probably the same guy. Professor, Department of Architecture and Center for Healthcare Architecture.
Oh, yeah.
Chalmers University of Technology, which is in Sweden.
Chalmers?
Well, it's probably not how you say it if it's in Swedish, but it looks like Chalmers. He's an adjunct professor of architecture at Aalborg University in Denmark.
Maybe he's not been publishing in English.
See, but he's the co-founding director of the Center for Health Systems and Design at Texas A&M, which is where
he should speak English then.
Where he published a lot of his research, specifically the one that I found.
Okay. Well.
It says in 2006 he was invited to Britain's National Health Service as a senior advisor on patient care environments for the UK.
Interesting.
When was the last time you were in the UK? Looking at hospital beds.
Well, when did I go in to look at the hospital beds? That was in...
Perhaps he hasn't had...
Ooh, I think it was in 2012.
So maybe he hasn't had time yet, though. He hasn't had time to affect the change that I would say Roger Ulrich would be...
They had some people from the British government coming to my hospital to look at our procedures.
Yeah, maybe we're ahead in those kinds of things. Although it doesn't seem that way because America spends so much on healthcare and we're not that
We
healthy.
overspend.
So
That's another topic for another time.
all right. Well, that's all I have.
Okay.
Anything else you want to add?
No, interesting topic, brother.
Okay, cool. So that's our episode on healthcare design or
Hospital design.
Hospital design.
All right.
And there's probably a lot more information that we didn't cover. So if you're interested, you should do more research yourself.
Maybe you should look into Mr. Roger,
yes.
Dr. Roger Ulrich.
Yeah, start with him. He seems to know what he's talking about. All right.